Hey, home health heroes. This is Amy Register with the Home Health Mentor, Teresa Register, a consummate professional who's been doing this home health care thing for so long, all of my life, really, and even headed to it a few years before my life when she was in nursing. She's got a long history of doing everything from nursing all the way up to serving on boards, being an administrator, and being a accreditor for an accrediting agency. So she's done it all. And we're back this week, kind of part two. Ooh, I put the wrong slide up. Oh, that's a bummer. Anyway, we're casual here today, and we are continuing on the track that we started last time, which is right aids. We're doing right aids part two. So let me hand it over to Teresa Register to get us started today. Hi, Mama.
Okay, thanks, Amy. So, yes, 2 weeks ago, we talked about the level one standards that Medicare applies to home health aid services for certified skilled home health agencies. We also covered the first of 6 level two standards, specifically looking at competency evaluations for aides. So today I wanted to continue through that list of the level two standards because, as I mentioned last time, the home health aid section of the conditions of participation have quite a few standards under it, and the surveyors look really closely at this because home health aides, frankly, spend the most time with patients and are the closest to patient care of any of the professionals. They're the ones that have the hands-on with patients, able to look at their skin. A lot of times, they're the ones the patients talk to the most and share information, even personal information with. So,
Yes, we love
so
them.
yeah, so home health aides are really important, and surveyors understand that. So
Hmm.
they're looking really closely at how agencies train and supervise home health aides and look closely at the care plans that are made for aides and then how the aides document the care that's being provided. So this really is a big concern for agencies if you're wanting to make sure that your patients are getting good care and that care is being documented. You really should pay close attention to this condition.
This is totally off the cuff, but at some point, we should talk about how to hire good home health aides. I bet there's a lot of new agencies struggling with recruitment and retention and, getting the best of the best. Let's put that on our future notes topic.
I think you're right, Amy. There are a lot of challenges just generally finding staff right now. Home health as an industry has grown a lot, and we know the population as a whole is aging. And so there's a bigger demand for home health services. So it really is an important topic. So, yeah, maybe we can spend some time on that at some point.
Yeah. Okay. Sorry to interrupt. And
But
also,
that's
hi,
okay.
Janesh.
Hi, Janesh. So, so looking at the level two standards, the first one that we covered a couple weeks ago was 48480, C1, 2, and 3, or G tag 768. And the title of that standard is competency evaluation. So we did talk about that. You can go back and listen to that podcast if you would like to. And then what I'm going to cover today is uh, a standard that starts with the CFR 48480D, G tag 774. And I'm giving that to you in case you want to put that in your browser and and read
I'll look
some
it
more
up
specifics
as we
about it.
go
Yeah,
along. I
right.
got you.
So the requirement for this particular level 2 standard has to do with in-service training hours. And the standard says a home health aide must receive at least 12 hours of in-service training during each 12-month period. So the question is, what's considered training? Some agencies have contracts for online training. Some agencies do in-classroom training, and
Mm,
and some can even have like self-instructional packets on standard topics on, for example, infection control or safe lifting and moving of patients. There's different ways this standard can be met, but specifically, it should equal at least 12 hours in each 12-month period. So it gets into some gray area unless an agency has a policy that says that those hours can be prorated
mm,
depending on the period of time someone was hired. Some agencies say that, their policy is that the employee will be, um, they will have 12 hours between January 1st and December 31st. I would not recommend that because if you hire someone um, late in the year, you're still going to have to try and get their hours of education. So what the policy statement should be is 12 months of their hire from their hire date, that kind of thing,
ah,
from
yes.
their hire anniversary. But it does make a difference how an agency writes their policy on this. So there is another question that comes up during a survey, and that is, what if an agency is hiring someone who has just completed their aid training and they had a competency evaluation by that training program?
Hmm.
Obviously, you would not necessarily think that you should redo every one of the competencies. However,
Right.
that said, most agencies do want to have an aide re-demonstrate competencies just for their own comfort, and they want to make sure that the person is comfortable doing those skills. As far as Medicare goes, though, Medicare says that you don't have to do that the first year after someone completes their training program, as long as it covers all of the required content, which any state
Hmm.
approved program is going to. So that's something to consider. But like I said, most agencies do want to have their own nurses check each
Yeah.
aide upon hire to make sure that that person's comfortable with the skills.
Yeah, it's like, you didn't actually get to see it with your own eyes, so it probably just feels really good to be yeah, to be able to check it off your list and know, "Okay, my aide, yes, they were certified and approved at the state level, but I have watched them work, and I'm so comfortable putting them on the front lines."
Right. Or they might need a little bit of, extra help, which you would want to know as well. So, um, a
Good.
couple other things about this, about aid and aid training issues. One thing that I saw fairly frequently as a surveyor was in small agencies, you might have just a handful of patients, and you may not be able to employ an aide full time. So that
Mhm.
aide may work for 3 or 4 home health agencies,
Ah, that's a
and
good idea for cost saving from the beginning too.
it is. But from a
Okay.
training standpoint and from documenting their training and their competencies, it gets a little bit ridiculous for the aide because
Oh, yeah.
because the aide then has to be able to, show that they've had their training in each of the places where they work. So, one of the suggestions I have for agencies that might be in that situation is to make sure that you have some kind of a standard that you require for documentation of training, and that you at least consider accepting outside sources and documentation as equivalent to your training program.
Oh,
So,
Mom, you know
yes,
what? We talked last time. It's been a couple of weeks, so I'm refreshing my own memory. We talked last time about creating this little aid simulator, competency simulator room, you
yes,
know?
yeah,
This is such a better argument for that. Like in a bigger city where aides might work for, yeah, a couple different agencies.
right.
If we had the coolest home health aid simulator room, then they could share that. The agencies could send it to a third party. Would that work?
Yes, yes, it would.
Okay, we're doing
Yeah.
it.
So there are some requirements for the quality of the documentation of training. So you have to have, an appropriate person doing the training. Obviously, you would not have another home health aide doing the training because that would not pass a Medicare inspection. But you would have an RN that is a qualified person to do the aid training and check them off on their competencies. You would also have
Mhm.
that same documentation showing, the actual credentials and signature from the trainer and from the person being trained. You would have some kind of a tool that measured that learning occurred. So a post test, pre test, some kind of thing like that. So the aid training is one thing, the documentation of that training is just as important. So
Right.
if you do
You need
use
to do
any
it
outside
and you
training,
need to show your work.
yes, and
Um,
if you accept, some outside training, just make sure that you know the quality of that training and that you
mhm.
document that it's equivalent to the training that you would be doing internally.
Janesh had a comment here. He
Okay.
says, we have nurse and aide go together on day one for review of plan of care.
Yes, that's good.
All right.
Yes.
Cool.
And we'll be talking a little bit more about that issue because that is one of the areas that is most cited, and I'll go into that a little bit later.
All right.
But
Carry on.
so one of the things that is acceptable is that bedside in services are also perfectly valid. You don't have to be in
Mhm.
a classroom. You don't have to take a post test and write it. But if there is some kind of a training that's done at the bedside, here's what Medicare says about it. Medicare says that if you're going to do that, you have to let the patient know that it's a training situation and they have to be okay with that. They have to give their consent to be part of a training situation, and that has to be documented if that's what you're going to do. And
Mhm.
again, you have to show what you covered and that the aide was able to perform, whatever you're training them to do, that they would have to be able to do it satisfactorily. So again, the bedside is a great place for training, but
Mhm.
just make sure that you document that the patient was informed that it was going to be a training session and they consented, and that the aide did or did not perform satisfactorily. So it's a good option. It's a great option if you can make that work.
Do we have a little sample of what that would look like a little write up, a permission, kind of a permission slip?
Um, well, No, I don't have one because generally the nurse that is doing the training just documents it in the
In
visit
the
note.
notes? Okay.
Yes. And then they document the training in the aides personnel file so that it counts toward their 12 hours of
Okay.
training.
Cool.
Um, I could do one, but I don't have one. If somebody thinks that that would be valuable, they can make that comment and I'll be happy to share one.
Okay.
Okay, so that I think that pretty much covers that topic. You just want to make sure that if you have any question about the training hours and whether or not the aide has had the right content, there are some specifics that are training requirements for home health aides. Um, some are defined just generally in your policies, like infection control, safety, lifting, moving, any abuse. Um, there's a couple new caveats in in the skills checklist for communication, barriers, boundaries. I'm trying to think. There's a new requirement that you competency an aid on their ability to identify skin conditions. So those are all good areas of training for home health aides. Make
Mhm.
sure that make sure that your content is appropriate. And maybe a final statement is don't use the same thing year after year after year. Update your training.
Mhm.
I've seen some agencies that use the same training year after year, and the staff gets really tired of that. So make some changes, upgrade it, update it, use something
Yeah.
different. Yeah.
At least new stories and illustrations,
Yeah.
even if the core info
Right.
is the same.
Right. Okay. So the next one is 48480G2 and G tag 800. This
We're
covers.
rolling right along here.
Yes. So this covers services provided by a home health aide. And this requirement says that home health aide services are services that are one, ordered by the physician, two, included in the plan of care, three, permitted to be performed under that state's law according to their guidelines, and four, consistent with the home health aide training. So there's a little bit to unpack here. Obviously, when the physician signs a plan of care, the person who assessed the patient's needs initially is going to include the specifics for the home health aide services, but they're not going to, list every single thing on that order. When the physician signs the order, it's as an extension of the nursing services or therapy services. And so it's only going to come into question if the professional makes a plan of care for the aide and the aide fails to follow the plan of care outlined by the professional. So it's deemed that that service has been ordered by the physician when the nurse does the plan of care or the therapist does the plan of care. It's as though the physician has ordered that. So it's really important that agencies understand that the plan of care that's made out by the professional nurse or therapist is considered an order, and therefore the aide has to document exactly compliance with that plan of care. If the aide doesn't follow the plan of care for whatever reason, which could be that the patient declined that particular service that day. They didn't want, they didn't feel up to having, a bath that day, so they refused it. That's legitimate. The home health aide must, however, document that it was declined, refused, whatever, terminology the agency wants you to use.
Mhm.
But then you have to document that that was reported to whichever professional is the case manager. It could be a therapist, could be a nurse, but it has to have been reported to that professional that the patient declined that service. And that's for a couple reasons. One is, for example, if a patient is post surgical, for example, and and they have not been getting in the shower, but today they feel great and they want to get in the shower, but that's not on the care plan,
Mhm.
then the patient has to be reassessed by the professional before the aide can go along with that. So the aide could call and get a verbal okay if the nurse or therapist has seen the patient recently and says, "Okay, yeah, I think they're safe. That's fine. Go ahead."
Mhm.
Or they will report it to the nurse or the therapist, and that professional then has to go back out to the home and reassess that patient and either update the plan of care for the aide or leave it the same, depending on their professional judgment. So, the thing to remember is that the type of bath that the patient wants to have is usually the first sign that the patient's either feeling better or their condition is declining. So,
Hmm.
of all the things on that care plan, the bath is the thing that is probably the most important to pay attention to and to make sure that they do it exactly the way it's ordered.
We should have led with that because that made a whole lot more sense to me than the other stuff, but, of course, you guys know I'm not a home healthcare pro, I am a learner. I'm here to ask questions along with you, but, okay, that's good news. The kind of bath is indicating, their desire for the different kinds of bath are indicating how well they're doing, in recovery or if they're going downhill. Huh.
Right. So if there's a change and it happens one time because say the patient is refusing a bath, but then the aide documents that maybe a daughter was visiting and already assisted the patient with a bath. That's
Oh.
important
Mhm.
information to put on the note, but still report that to the nurse.
Mhm.
So the nurse doesn't think that the patient's declining. That
Mhm.
would just be, a perfectly appropriate explanation of why the aide did not give a bath that day.
Yeah.
so,
I just
so
took a bath.
yeah, I don't need another one.
Yeah.
Yeah, so that's the kind of thing that is really important about the plan of care for the aide. Uh, I will tell you honestly, what I always did was I printed off the aid plan of care, and then
Mhm.
I would look at every note for a period of time. I would look at every aid note, and I would look for consistency, absolute consistency between the plan of care and the note. And if it did not match up, that was an automatic citation. So
Uh,
yes, and that's
Gasp.
why I'm saying this is really important that people understand how significant the plan of care for the aide is, not just from the standpoint of the aide and following the plan of care, but for the professional who is supervising that aide. If that plan of care was made out carefully and appropriately, then the notes every time the aide visits that patient, the notes should reflect that consistency. And if it doesn't, the RN or therapist needs to be out there to the patient's home promptly to find out what's going on. For example, say the aide writes in their note that the patient declined a bath. This was reported to, I'm a nurse RN, and I have seen that kind of a note 3 times in a row with no visit by the nurse. To me, that is obviously a problem, and that would be cited under a failure to supervise, and that would be a
Oh.
second citation. So you can get 2 citations out of this.
Yeah,
One for
so
the aide
one
not
time the
following.
aide is in trouble, but if you keep doing it, then the supervisor's in trouble, and of course, this puts the whole agency at jeopardy because now
Exactly.
we got a problem.
Yes. So there's a communication breakdown here somewhere that could
Mhm.
put that patient in jeopardy. So
Man, you
this is
know what? I'm saying this, I'm not trying to give you more work to do, but I'm just saying, like, as a learner coming along with the community who, is just learning this stuff, um, I know you couldn't have an actual one of these, but if you could show me, like, a split screen version of what the notes look like and then what you're printing off and, like, show us, here is the plan of care, here's the notes, and show us, like, little things that might be overlooked, that would be super cool one sometime.
Yeah, well, I can tell you when a surveyor writes a citation for this kind of thing, it is all spelled out, every single, issue. For example, if the plan of care said the patient was supposed to have a shower and the patient had a bed bath instead, that is in the citation. It's actually listed as a problem with, the incongruence between the plan of care and the visit note.
Oh,
So,
yeah. Yeah, once you get
so
cited, you know everything,
yes, it's
but then
it's
it's too
listed,
late.
the visit note, the date of the visit, what was ordered but not done, what was done but not ordered, which is a whole nother ball of wax.
Mhm.
So yeah, there's things that are not on the plan of care that the aide will do sometimes and document it, and that's just as bad as if it was on the plan of care and not done. You're not supposed to do things that are not on the plan of care. And sometimes, I've had people say, "What? You're penalizing us because we did more?" And it's like, yes, because in some cases, the nurse specifically wants the patient to do that for themselves so they get better. So they're
Mhm.
not, becoming more dependent, they're becoming more independent. So if the nurse thinks that the patient can feed themselves, then do not go overboard trying to help them feed themselves. Don't help them dress themselves if they can dress themselves because they need to become independent. So,
I have so
this,
many questions, but we're already at, like, 28 minutes, so I'll just be quiet, but it seems like coordinating care, like, knowing that your patient's also seeing a PT/OT or and what that might do for them and, stuff like that is such a huge thing if people are receiving services from several places, so
you are absolutely right, and it does get into coordination of care. That's exactly why there is a lot of emphasis in the survey process on coordination of care, just for these very reasons. Um,
I'm
if
feeling a
someone
great need to pay, home healthcare heroes more money after this.
Yeah, they're amazing. I've just worked with some amazing people, amazing home health aides. They are generally just the heroes, the
Hey, if you're
true,
listening
the
to
true
this
frontline
now
heroes.
or if you're listening to this now or up until, um, a year from now, if you hear the sound of my voice until August 6th, 2022, and you have a home health care aide who needs a pizza, That's in my budget. Please contact me and I will send pizza. And if I pass away, my mom will send a pizza on my behalf. All right, carry on.
Okay. Um, so I'm actually not going to get through all of these today because I don't want to keep everyone much longer. So as far as services provided by the aid, GTAG 800, we were going through the services have to be ordered by the physician, has to be on the plan of care, has to be able to be performed under that state's laws and are consistent with the home health aid training. So the other part of this I wanted to say is that state laws vary, so you do have to know what is permitted under your state law. Secondly, where the standard requires that it be consistent with the home health aid training, what what comes into play there is there are certain things that aides are just routinely trained to do in state training programs, but there may also be some things that a specific patient needs that the
Mhm.
aide may not have been trained on, and that's where that bedside or in service um,
Mhm.
situation comes into play. So, for
Mhm.
example, um, my nephew has a standing frame. If an aide was to go out and work with him and had never worked with a standing frame,
Mhm.
they might need specific bedside instruction on how to help him get into the standing frame, how to secure the belt for safety, that kind of thing. So it's not just that checklist that you want to go
Mhm.
through, bathing, combing their hair, shaving, that kind of stuff. You want to make
Mhm.
sure that if there's something unique about each patient's needs, that you document that they've been trained on that as well.
Very cool.
Okay. I think we're going to have to stop for today. I think we're going to have to go to a part 3, Amy.
No, let's not go to part 3. Like, this is so specific stuff. I mean, and these things you mentioned before where people can find this and read it, they can ask you questions. Um, is there any way, like, I'm just kind of going through your notes here, but are there any kind of final tips that you could leave with this topic? Just reviewing from our first one, this is so often cited because it's so important and so specific.
Yes.
Um, and there's no way we could cover it even in 5 sessions thoroughly.
Well, the one thing that a lot of states vary on is on medication administration. And so one thing that I would say is there's there are states that allow home health aides to assist in medication administration, and each agency administrator and clinical director need to really pay attention to that. Um, Most states only allow aides to have a passive role in administering medications, which means bringing the medication to the patient in a pill organizer or a medication container, maybe getting a glass of water or something for the patient to take to take their medication with, reminding a patient to take their medication, putting on a topical cream or lotion, that kind of thing, but
There
nothing that
you
is
go. There you go.
prescription.
Sandy was just asking that. I don't know if you could see that in the comments, but Sandy wants to know, can the home health aide apply a medicated cream to the skin? Is
If it's a non-prescription cream, yes. If it's a prescription cream, no. In most states, but again, they should double check in their state, and they can even call and ask a state surveyor something more specific if they don't see it in the regs. But a topical product which is non-prescription to intact skin, normally that is just fine.
cool. Thanks, Sandy.
Good
Um,
question.
yeah. Yeah. So I'm sure everybody remembers or knows where to go to get more information on this. And you mentioned it last time, but what do you tell us
Well,
again?
the the place, there's actually a number of places to go, but what I usually refer people to is called the State Operations Manual and Interpretive Guidelines, because that's where you're going to find not only the conditions of participation and the standards with the CFR number and the GTAG information, but it's also going to give you the same information that surveyors get to help them interpret the standards. So for
Mm-hmm.
home health, it's the State Operations Manual, Appendix B.
Okay.
So if they just put that in their browser, up will come that State Operations Manual with definitions and guidelines and a lot of good information.
Okay. Well, should we leave it there today, or do you want to wrap up with any overview top
I would
tips?
just, I would just let me just say that the last section there, G820, CFR 48480, H5, covers if an agency contracts for home health aid services with another organization. Just know that it doesn't, what matters is how you supervise and ensure the quality of those services. If there's a problem, the surveyor is not going to hold the other organization responsible. They're going to hold you responsible. So make sure that you contract carefully and you still are comfortable with the quality of those services. You're expected to supervise. You're expected to know the quality of those services.
That's awesome. I think everyone should have a big enough family and friend circle that their contractors are caring for one of their own. That way they could really know what's going
that's
on.
that's true.
Yeah, and I
Okay,
could see a
well,
whole other
I
side
was just going
hustle.
to say if there's more questions or concerns, I'd be happy to have people send me their questions and I can maybe be more specific or more helpful.
Yeah. Yeah, and we started this as a place for you guys to come and really ask your questions. So we'll continue with topics that we're picking that we think are pertinent. Well, mostly my mom. I just want to talk shop and gossip all the time. I like her stories. I like her stories from the inside. But when you have questions, hopefully you've simulated some of those in your mind and given you a place to have a little sounding board. So I hit my mama up. Facebook is probably easiest for her. Facebook Messenger. If you leave comments on the YouTube, I'll do my best to pass them on because I don't think she will check them very often. But we're thankful that you joined us today, and we know that doing what you do is not easy. If you're an aide listening to this, thank you so much for doing what you do day in and day out, loving people and helping them, and trying to follow that plan of care consistently, point by point. So don't get citations. And
So so they can find me at the Home Health Mentor on my Facebook page. And I
yes.
do try to check that fairly frequently and try to respond. Sometimes I'm traveling and I don't get to it as quickly as I'd like to, but just hang in there and I'll get back to you.
Oh, yeah. And I also wanted to show off one more thing because you guys know we have been working on our website little by little. And I do have a t shirt I want to show you that's at thehomehealthmentor.com. This is our educated, dedicated, caffeinated home health nurse. So you can check that out at thehomehealthmentor.com. All right, that's it for today. Mama, do you know what we'll talk about next time? Can we have stories from the
Stories from
crypt?
the crypt.
Yeah.
I'll see if I can come up with a few funny anecdotal stories.
Yeah, and we'll make sure that they're on topic and they have something to do with what we can help you with. But that's it for now. Hang out with my mom on Facebook, the Home Health Mentor, and ask any questions you want to get in before next week. Thank you. Bye for now.
Bye.